Thanks for that kind introduction. Today I'm going to talk on routine lab biomarkers. Let me share my screen. So routine lab biomarkers for chasing the storm. So here I will discuss some of our case studies and also being the executive member of scientific division of IFCC and chair of American Association of Clinical Chemistry India section. I will share some of the direct tips given by IFCC and AECC regarding routine lab biomarkers for prognosis and or for therapeutic monitoring. So this is my painting for us diagnosticians or lab physicians or the people, the personnel in lab. For us, every blood sample tells us a story. We may be doing the test under RT-PCR or autoanalyzer or seeing the slides under microscope. So we are helping by extending our hands to heal. And so this is, I here acknowledge all the diagnosticians present. And during this COVID-19 time, we realized the role of the lab personnel and diagnosticians and lab physicians. So this painting is to acknowledge all our efforts. So this is some of our recent articles and in original articles on routine lab biomarkers and cardiac biomarkers in patients with COVID-19. And these are some of our news articles and some of our story or case study in different newspapers and like Express Healthcare, Dainik Jagran, and ACC's newsletters, CLN News, and all. So actually, during this time, we realized that how resilience is the key to decode the lab diagnostic during this pandemic to chase the storm. So I'll start with one of our case study during the initial 2020. So 67-year-old male known case of diabetes, hypertension, CKD on maintenance hemodialysis, COVID-19 positive on routine evaluations by our RT-PCR SARS-CoV-2 was detected, and patient clinical features were very high grade fever, breathing difficulty, chest X-ray showed bilateral infiltrates. Then what next? So then comes the role of several biomarkers or routine laboratory parameters like CRP or C-reactive protein. Here, this is around very high, 17.3 nanogram per ml. Then if you see different other markers like liver function test, D-dimer is raised, ferritin raised more than 40,000, LDH raised 745 unit per liter, and then creatinine increased, ABG arterial blood gas deranged, then in CBC, WBC count increased, neutrophil lymphocyte ratio deranged, neutrophil increased, lymphocyte decreased. Then interleukin 6, which is cytokine, is increased like 650 picogram per ml. Procalcitonin is high, 2 nanogram per ml, and the cardiac involvement is seen by raised high sensitive troponin I 45.9 picogram per ml. So this is a picture of cytokine storm. By seeing this picture, we can say like this is severe case of COVID pneumonia and along with cardiac involvement. So cytokine storm is raising, now coming to every day we are reading in newspaper about different variants, and multiple variants of SARS-CoV-2 virus have been circulating in and around the world. According to Center of Disease Control and Prevention, CDC, there are 3 classifications, namely variant of interest, VOI, variant of concern, and variant of high consequences. And if we see different variants like UK variants, B117, it was there in southeast of England, and it was variant of concern, and experts suggested during the first wave this variant was 40 to 70% more infectious than the other variants and raises death risk to 60%. Then Brazil variant P1, and this is more contagious and dangerous than the previous mutation E484K. This is an escape mutation, allows the variant to evade the antibodies. Then South African variant B1351 was found in at least 20 countries and now more, including UK. And this is akin to Brazil variant E484K mutation, so which allow this variant to dodge the antibodies. And additionally, there is M501 mutation, make it more contagious. And then Indian origin, initially double mutant virus variants termed as B1617. It was identified around the March end in the state of Maharashtra, and it continues to drive India's second wave of coronavirus. It contains E484Q and L452R mutations, which makes it more infectious and enables it to escape antibodies or immune escape. So additionally, recent reports suggest that triple mutation COVID variant has been identified in different parts, Maharashtra, Delhi, West Bengal, and multiple other parts. And this virus evolved to sustain their lives and improve the infectivity. So double mutation crisis we saw during the second wave in India, and the 2 mutations was prevalent, and the triple COVID mutations also we saw. And this was termed initially as Bengal strain because it was identified predominantly circulating in West Bengal and also different part of Maharashtra later. And deletion of H146 and Y145 and mutation in the E484K and D614 gene spike protein. And this triple mutant variants is the second lineage of SARS-CoV-2 virus to be identified in India, and is being called as B1618, and it has increased infectivity and immune escape phenomena. So these are different coronavirus variants and in different continents. And if you see SARS-CoV-2 variants renamed by WHO released new nomenclature to denote variants of SARS-CoV-2 that may make the coronavirus more dangerous in an attempt to simplify their name and discourage the practice of associating this to region-wise. So this new WHO, the variant of concerns are alpha, beta, gamma, delta, and there are several variants of interest. And B117, like alpha variant, it was there in UK variant, and B1351, beta variant, South African variant, P1, gamma variant, Brazil variant, and B16172, the Delta variant, Indian variant. And so this was named, and now Delta Plus variant. So Delta variant of COVID-19 mutation, it mutates into Delta Plus, and the highly transmissible Delta variant of SARS-CoV-2 has mutated further to form the Delta Plus or AY1 variant, and B161721 variant characterized by the acquisition of K417N mutation. And the mutation is in the spike protein of SARS-CoV-2, which helps the virus enter and infect the human cells, they said. And Delta Plus variants have been identified from India, US, UK, Canada, Germany, Russia, Nepal, Switzerland, Poland, Portugal, Japan, South Korea, China, and many other continents. And B1617 Delta Plus, the variant of concern, is becoming dominant variant globally, and because of the increased transmissibility and impending third wave scare and resistance to monoclonal antibody cocktail treatment by this. So this is Delta Plus variants. Currently, variant of concern has this characteristic: increased transmissibility, stronger binding to receptors of the lung cells, and immune escape, and potential reduction in monoclonal antibody response. So it's formed due to mutation in the Delta B1617 variant, and one of the emerging variant is B161721, also known as AY1, characterized by the acquisition of K417N mutation. So the mutation is in the spike protein of SARS-CoV-2, which helps the virus enter and infect the human cells. And according to Public Health England, 63 genomes of Delta B1617.2 with the new K417N mutation have been identified, and this increasing vaccination and monitoring of the new variants are essential in fighting this COVID pandemic. So as the overall number, this is recent report, August 2021 report, overall number of coronavirus cases in India is on a downward trajectory, though around 35,000 cases continue to be added almost daily. Nearly 3 in 4 of these infections are from Kerala and Maharashtra, and there may be several reasons why this is the case. And one of the conjectures is that the newer variants may be playing a significant role. The weekly update is there, and it says that Indian SARS-CoV-2 Genomic Consortium, a repository of labs tasked with monitoring variants of coronavirus, says that the Delta variant remains most responsible for the continuing spread of the infections in India. So it collects percentage of coronavirus positive samples for analysis from all states, and of the nearly 50,000 samples analyzed for their genetic composition, about 2/3, 230 were among the internationally classified variant of concern or variant of interest. And of these, nearly 20,000 were the Delta variant, AY2, and about 5,000 it's associated with lineages like AY1 and AY3. So because they contain mutations that help the virus avoid detection by the immune system, the lineage of the Delta variants are driving spikes in infections worldwide. And globally, there are believed to be 13 lineages, sublineages of Delta with characteristic genetic mutations. AY1, AY2, AY3 are the predominant ones. So Delta is B1617.2 has become the predominant lineage in India and different parts of the world. Globally, there are believed to be 13 sublineages of Delta with characteristic genetic mutations. So, and AY1, AY2, AY3 are the predominant ones in India. AY3.1 is recently classified sublineage of AY3 in US, and AY12 is a sublineage of Delta recently classified from Israel. So one of these variants, the Delta Plus variant, also known as 161721 or AY1 was first detected in India during February, and as of 24th August 2021, the state of Maharashtra has already recorded 103 Delta plus cases. So Delta plus differs from Delta because of an extra mutation K41N located in the spike protein, which covers the surface of the SARS-CoV-2 virus, and the K417N mutation is not entirely new. It has arisen independently in several viral lineages, and the Delta plus variant was designated as variant of concern on 2nd June by the Indian government, citing that its perceived increased transmissibility and ability to bind more strongly to receptors on lung cells and potential to better antibody response or immune escape. However, it has not yet been designated as variant of concern by WHO, neither by US Center of Disease Control and Prevention, CDC. So now coming to different phases of the disease, like the first phase is stage 1, where there is an early infection, viremia, then acute pneumonia stage or pulmonary phase, stage 2, and next stage is hyperinflammation stage or stage 3 or recovery. So if we see different clinical symptoms in stage 1, like mild constitutional symptoms or mostly asymptomatic, or we see sometimes dry cough, diarrhea, headache. And there are different kind of symptoms we see, and with mild fever. And during the pulmonary phase or stage 2, we see shortness of breath, hypoxia, and stage 3 there, when there is a hyperinflammation stage, we see ARDS and SARS or show off or cardiac failure. So we see acute respiratory distress syndrome. So if we see here, during the viremia stage, we see lymphopenia, increased prothrombin time, increased D-dimer and LDH, mild increase of LDH. And then during the pulmonary phase, abnormal chest imaging, transaminitis, low normal procalcitonin, and during ARDS or hyperinflammation phase, we see elevated inflammatory markers like CRP, LDH, IL-6, D-dimer, ferritin, and cardiac markers also. When there is a cardiac failure or cardiac involvement, we see increased troponin, high sensitive troponin I or troponin T or NT-proBNP elevations. So these are different potential therapies. And now clinical presentation. As per CDC, the people who are affected with COVID-19 has wide range of symptoms ranging from mild fever to severe illness, incubation period 2 to 14 days. After exposure of the virus, many people are asymptomatic. Basically, during this time, we saw like people have taken 1 dose or 2 doses of vaccine. So mainly we are seeing many asymptomatic cases or mild symptomatic cases, and major symptoms: fever, chills, cough, tiredness, muscle or body aches and pains and sore throat. And in some of the cases, congestion or runny nose, GI symptoms, nausea, vomiting, diarrhea, skin manifestation, rash, neurological manifestation, headache, new loss of taste or smell also observed. Other serious symptoms of visible emergency warning signs are difficulty in breathing or shortness of breath, persistent chest pain or pressure in the chest, new confusion or inability to wake or stay awake, or bluish marks on the lips or face. So, and it has effect on respiratory system, leading to the rapid development of pneumonia. It also leads to acute respiratory distress syndrome, ARDS, and multi-organ failure in case of severe infections, which may lead to death. And it is seen 10 to 15% of COVID-19 cases may lead to severe interstitial pneumonia, and it progressed to acute respiratory distress syndrome. The risk of severity and mortality have been observed to be much higher in older people and in person with underlying comorbidities such as hypertension, cardiac disease, chronic lung disease, and cancer. So this is 41-year-old female with SARS-CoV-2 positive. If you can see, there are multifocal ground glass opacities without consolidations in CT, chest CT, and during this second wave, we saw a lot of young people admitted in ICU, or a lot of young people involved. So this may be due to because of lockdown has opened, and because of that, these are mainly the young generation, mainly the bread earning generation. So because of social distancing and all was less, and this may be the reason where we were seeing the case during the second wave. The mostly it was the young people was involved, and as SARS-CoV-2 and COVID-19, we all know this is a severe acute respiratory syndrome related coronavirus. It shares 79% of sequence identity with SARS-CoV, and it has spike, membrane, nucleocapsids, and envelope. And this is spike protein, then envelope, and protein, and then membrane glycoprotein, and nucleocapsid protein. So in SARS-CoV-2, the spike protein binds to the angiotensin converting enzyme 2-ACE2 as a receptor for the cell entry. After the spike protein binds to human cell receptor, the viral membrane fuses with the human cell membrane, allowing the genome of the virus to enter the human cells and begin the infection. So studies have also shown that the S protein plays major important roles in viral attachment, fusion, and entry, and it serves as a target for development of antibodies and entry inhibitors and vaccines. So ACE2 expressing cells are alveolar epithelial 2 cells, lymphocytes, and extrapulmonary tissues like heart, kidney, and intestine. So the pathophysiology based on the structure, like we see early in infection, SARS-CoV-2 target cells such as nasal or bronchial epithelial cells and pneumocytes through the viral structural spike protein or S protein that binds to the angiotensin converting enzyme 2 or ACE2 receptor. So that binds to ACE2 receptor, and then the type 2 transmembrane serine protease TMPRSS2 present in the host cell promotes the viral uptake by cleaving the ACE2 and activating the SARS-CoV-2 S protein, which mediates coronavirus entry into the host cells. So there is a coronavirus entry, and then this ACE2 and TMPRSS2 are expressed in host target cells, particularly alveolar epithelial cells. So if we see, so there is SARS-CoV-2 viral release inside the cell, and if you see, there are T lymphocytes, monocytes, and neutrophil recruitment, and then cytokine release enhances the inflammatory response, and then there is increased T lymphocytes, apoptosis, then influx of monocytes and neutrophils, and activations of coagulation leads to microthrombi formations, then pulmonary thrombus formations, hyaline membrane formation, thickened interstitium, and pulmonary edema, and continued inflammatory response results in alveolar interstitial thickening and increased vascular permeability and pulmonary edema, which leads to ARDS or acute respiratory distress syndrome. So this is the pathophysiology. Now coming to the lab's role. So of course, Dr. Ashok Ratan Sar is there. So he is the authority for COVID-19 detection. And so I will just mention the name, mention what are the lab roles. I'll give the bird's eye view, by our RT-PCR, the diagnosis, of course, the main important. But if we come to staging, prognostications, therapeutic monitoring, so there are different lab biomarkers which play significant role for staging, like mild, moderate, severe cases, then prognostication of the COVID-19, and also therapeutic monitoring. And coming to epidemiological surveillance, anti-SARS-CoV-2 antibodies play significant role. So now, to predict the progression to a severe or critical form of COVID-19, like leukocytosis, neutrophilia, lymphopenia, we see during the initial stage, viremia stage, we see lymphopenia, NLR ratio derange. Then prognostication purpose, increased values of LDH, then transaminitis, ALT, AST raised, total bilirubin increase, creatinine increase, D-dimerase, prothrombin time increase. CRP is one of the major important marker for COVID-19. CRP is raised, and this is one of the most important inflammatory marker. Then interleukin-6 raised, then procalcitonin sometimes increase. Then if there is cardiac involvement, cardiac troponins raise, NT-proBNP increase, then decrease values of serum albumin. So if you see, this is our study in Kokilabendi Rubai Ambani Hospital, we saw these are the percentage of cases where in total number of patients, like for example, CRP is raised in 79% of cases, D-dimer around 80% of cases, ferritin around 56% cases, LDH 42% cases, creatinine 31% cases, interleukin-6 73% of the cases, because ours are mainly the COVID ICU. So we saw high sensitive troponin I, NT-proBNP around 25% of cases raised, and the procalcitonin 30% cases, and abnormality of ABG we saw around 52 to 58% cases. So this is our KDH study. And now if we see like early stage, where we see eosinopenia, lymphopenia, and then week 1 we see CRP, ferritin, LDH, D-dimers, fibrinogen raised, inflammatory response in early stage, and then week 3 we see sometimes anemia along with cardiac and liver enzymes and neutrophilia, neutrophil lymphocyte ratio derange. Late stage we see organ damage, cardiac markers raise, and several other kidney damage and all. So this is kind of the phase, and these are the reason why we see those biomarkers derangement. So if we CBC, increase white blood cell count, and increase neutrophil count, decrease lymphocyte count, so and decrease platelet count. So this is due to bacterial superinfection or decreased immunological response to virus consumption or disseminated coagulopathy. And albumin decreased, then transaminitis increased, ALT, AST due to liver injury or widespread organ damage, and total bilirubin also increased due to liver injury, creatinine raised due to kidney injury, LDH increased due to pulmonary injury or widespread organ damage, and then cardiac troponin due to cardiac injury, D-dimer raised due to activation of blood coagulation or disseminated coagulopathy, then prothrombin time increased due to same reason, and CRP increased due to severe viral infection, viremia or viral sepsis, And ferritin increased due to severe inflammation because this is a pro-inflammatory marker. Cytokine like interleukin-6 increased due to cytokine storm syndrome, and procalcitonin increase many times due to bacterial superinfections. But usually we see procalcitonin in the range of less than 2 and not much more than 5. So procalcitonin is raised, but not more than 5, mainly in COVID-19 patient. Now coming to the difference between the classical macrophage activation syndrome pattern versus the COVID-19 related picture. So if we see classical macrophage activation organ pattern, and there it doesn't have any spatial tropism for pulmonary tissues, but COVID-19 related secondary HLH or macrophage activation syndrome, we see there is pulmonary tropism reporting of the classical organomegaly pattern, and where it is more confined to lung parenchyma immediately adjacent to the bronchial alveolar lymphoid tissues and associated with ARDS development. And another difference in classical, we see lymphoid organ hyperplasia, hepatosplenomegaly, and adenopathy. And in COVID-19 related secondary HLH or macrophage activation syndrome, we don't see any classical organomegaly pattern. So severe COVID-19 associated pneumonia, severe widespread alveolar and interstitial inflammation extends to closely juxtaposed pulmonary vasculature, elevated D-dimer formation seen in early COVID-19 pneumonia, macrophage activation syndrome like intrapulmonary inflammations resulting in a lung-centric pulmonary intravascular coagulopathy or PIC kind of picture presentations rather than disseminated intravascular coagulopathy presentation, and routine lab parameters suggesting that a subgroup of COVID-19 pneumonia cases also have macrophage activation syndrome or secondary HLH. So highly elevated CRP, hyperferritinemia, other features including coagulopathy and abnormal liver function, and immunopathology is very lung-centric and emergent ARDS and absence of organomegaly. Cytokine profile raised like interleukin-6 resembling macrophage activation syndrome or secondary HLH, and different other cytokines like IL-1 beta, IL-2, interleukin-6, interleukin-17, interleukin-8, and TNF. So we see the raised cytokines and serological markers associated with macrophage activation syndrome are hyperferritinemia, deranged liver function test with coagulopathy, clinical trials demonstrate evidence of efficacy for anti-IL-6 receptor blockade with tocilizumab. So initially during the first wave, tocilizumab was very popular at that time. They thought interleukin-6 receptor blockade tocilizumab, we need to have the baseline of interleukin-6. So but now we have seen like the rule is little restricted. So these are different long-term effects of COVID-19. You can see mostly all the organs are involved, and you can see the variety of presentation and the markers like abnormal chest X-ray, D-dimer, NT-proBNP, CRP, ferritin, procalcitonin, interleukin-6. So you get the different kind of presentation we see during the long-term effects of COVID-19. Now coming to another case, this is, I will, by this case history, I'll show how we have evolved during the first wave. This is during initial February 2020, and this is case of 56-year-old physician, history of fever, cold since 6 days associated with cough with expectorant, history of severe body ache and decreased appetite, mild hypertensive, history of contact suspected because that time he was seeing the patient, and history of similar complaints in host family. He started hydroxychloroquine on his own on day 3, and day 6 he had breathing difficulties, so he came to hospital. Our RT-PCR was positive. Now see the markers. If you see lab panel, CRP was raised to 21.6 milligram per deciliter, transaminitis, ALT, AST, GGT increased, bilirubin increased, then total protein increase, albumin decrease, triglyceride increase, LDH increase, ferritin increase, D-dimer raised, CPK raised, then blood gas showed derangement, then neutrophil lymphocyte ratio deranged, neutrophil increase, lymphocyte decrease, platelet count decrease, and monocyte, lymphocyte, and eosinophil, all absolute count was decreased. And now see, they started the treatment with paracetamol, ceftriaxone, hydroxychloroquine. When there was persistent high fever, day 9, increasing CRP, ferritin, they started lopinavir, ritonavir. You remember, this is the case during early 2020, February. See, sorry, single dose lopinavir, ritonavir, they have to stop due to high QTC, fever increasing, patient was desaturating, and chest X-ray showed bilateral infiltrate, cytokine storm is raging, high fever, increased D-dimer, ferritin, LDH, interleukin 6, acute lung injury treatment. They wanted to start tocilizumab during this time. So I remember early 2020, February, I got a call from our infectious disease specialist, Dr. Tanu Singhal, an intensivist from ICU. And they told me that they wanted to start tocilizumab, interleukin 6 receptor blockade, and because of that they want to do interleukin 6. That time interleukin 6 was not a very popular parameter. It was early 2020 February. So I remember I called the IBD manufacturers. I opened the vendors, the warehouse. So they supplied the kit immediately. Then our validation protocol is quite extensive. We minimum 7 days validation protocol, verification protocol. So I called College of American Pathologists and ACC, like what can be during the pandemic emergency validation protocol for interleukin 6. So then we followed. That time it was lockdown. I called the staff who used to do the validation or verification. So you see the consequences. We rushed to the hospital. We did emergency validation of interleukin 6, and I think within 3 hours we arranged the kit and then did the emergency validation and reported for this patient because the patient was critical. But with that also fever was persistent and inflammatory markers increasing and oxygen requirement increasing. And then they started methylprednisolone 30 milligram twice daily for 3 days, and then there was no fever, decreased CRP, no oxygen requirement, and patient was discharged. So this is like, if you see the roller coaster ride of this patient, and long hospital stay, and but he recovered. So this is how we have evolved during this first wave. And next is another case, 43-year-old, no comorbidities, including obesity, mild fever, cough for 2 days. So mild fever and cough, then test positive for SARS-CoV-2. And on day 2, normal oxygenation, no breathing difficulties, oxygen saturation maintained. But see the lab test, because they have done CBC, lymphocyte, platelet, CRP, interleukin-6, procalcitonin, D-dimer, HRCT, everything for these patients with mild fever and cough for 2 days based on WhatsApp recommendation. So this patient did all the tests. So this is very important to understand right test, right patient, right time. So do you think all the tests, the gamut of tests, all the routine lab markers from CRP to interleukin-6 to procalcitonin, are they necessary for this patient with mild fever and cough for 2 days? Not at all. So it's very important for us to understand like right test, right time, and right patient. So now coming to another case, 14-year-old female, fever since 3 days, rash since 2 days, SARS-CoV-2 positive, no history of contact, no history of travel, and fever, persistent oliguria, tachycardia, hypertension, RT-PCR was positive. Then in this patient, total immunoglobulin antibody of SARS-CoV was positive. And this is the case of pediatric multisystem inflammatory syndrome, or PIMS, related with COVID-19. And if you see, this is the trend analysis of different lab biomarkers. If you see this patient, CRP is, this is the trend for this patient. CRP is increasing, interleukin-6 increasing, then this is the derangement of ABG, and this is NT-proBNP is raised, high sensitive troponin I raised, very high cardiac involvement was seen in this patient. D-dimer increased, increasing trend of the D-dimer. Then there was neutrophil lymphocyte count range. And if you see this trend analysis, so this is the patient, this girl, 14-year-old girl, this is the case of PIMS, or pediatric multisystem inflammatory syndrome. So PIMS associated with SARS-CoV-2, where there is a multisystem inflammatory syndrome in children. So this we're seeing during the sometimes during the first wave, and mainly we saw many cases during the second wave. It resembles to Kawasaki disease or toxic shock syndrome, and where it can spread to blood vessels, vasculitis, particularly those around the heart, and if untreated inflammation can cause tissue damage, organ failure, even death. So this is Kawasaki-like disease, and PIMS can damage heart, and it tends to affect the children under 5, actually the Kawasaki, main Kawasaki. But PIMS associated with COVID-19 affect older children and teenagers. And actually PIMS with COVID-19 are RT-PCR positive, sometimes SARS immunoglobulin positive, and very small number of children with PIMS symptoms didn't test positive for either. So usually in this case, we saw antibody positive along with the RT-PCR positive. So mainly we see in PIMS cases because there is a multi-system involvement, and there are MIS, post-COVID MIS also very common, so where we see antibody increased. So now coming to cardiac and arrhythmic complication in patients with COVID-19, we have paper also. So original article, and we have seen that although the manifestations mainly respiratory, but major cardiac complications seen, and this multifactorial etiology comprising of direct viral myocardial damage, hypoxia, hypertension, enhanced inflammatory status, ACE2 receptor downregulation are main cause. And during this SARS-CoV-2 related COVID-19 cases, we saw a lot of cardiac involvement. Cardiac markers were raised, and HS troponin I, NT-proBNP, and where the cardiac injury markers show that it is associated with poorer outcomes, and arrhythmic events are not uncommon. And there are clinical cohorts where we have seen there are sudden cardiac death, and so because of that, myocardial injury, conduction system damage, decompensated heart failure, acute coronary syndrome, myocarditis, hypertension, tachyarrhythmias, bradyarrhythmias, drug-induced increased QT interval, like I explained during our one of our cases, and then sudden cardiac death. These are seen, the cardiac and arrhythmic complications associated patient with COVID-19. Now coming to inflammatory markers used in assessment of COVID-19. So CRP is most important marker, association with risk progression, severity and outcome. It helps in monitoring therapy, decision for second line therapy. And then coming to ferritin is correlated with increased risk of progression, severity and outcome. Then D-dimer is another important markers. Other markers like LDH. So there is rule of 6, like CRP more than 60 milligram per liter, ferritin and LDH more than 600 nanogram per ml. So this is associated with disease severity. So in resource poor setting, or in setting where we don't have gamut of tests, so CRP, ferritin, LDH may be sufficient, and sometimes D-dimer along with that. Coming to interleukin-6, it rises early, initially thought to be useful to guide IL-6 therapy, but we have to do judicious use of interleukin-6 and procalcitonin, because procalcitonin usually doesn't rise significantly in COVID-19 because it's viremia, but when there is a secondary bacterial infection, it increases. So because of that, CRP is the most important marker, along with CBC, where we see lymphopenia or neutrophil lymphocyte ratio derangement, and sometimes ferritin, LDH, and D-dimers. We need to use those inflammatory markers or routine lab markers judiciously. And this is very important to understand right time, right patient, and right markers. So smart biomarker, like it should be specific, sensitive, measurable, available, and affordable, and responsive and timely. So this is very important, and because of that, now we saw, because there is no lockdown, and also social distancing and all are not maintained. So this is the cartoon, so where one person is asking where is everybody rushing to after the unlock. So towards the third wave, I guess. So we need to follow the COVID appropriate behavior. We need mass vaccination. So mass vaccinations, masking up, and COVID appropriate behavior is are the only answer to fight against this pandemic. So here I want to acknowledge, we know clinicians, like how this pandemic, we have seen the role of the clinicians, how they have healed, and we lost many of our colleagues. And so this is my painting again to acknowledge the clinicians and diagnosticians. So, and if you see this extended hand, that is ours. So we are helping, and we have extend our hands to heal. So we are the healer. So here I acknowledge the healer, the clinicians, and diagnosticians. Thank you. Thank you so much.